Recorded.
Hopefully everyone can hear me. Welcome to the last Telehealth Learning Collaborative of 2019. This is, of course, hosted by the North Country Telehealth Partnership, which is a joint effort between Fort Drum Regional Health Planning Organization in Watertown and Adirondack Health Institute, where I am located in Glens Falls, New York. We have a packed agenda today, so I'm gonna not waste any time and start with our November speaker. So our November speaker is Sarah Cistolini. She's from UVM Health Network and is their telehealth program strategist, and she has been instrumental in the implementation of e-visits in adult primary care throughout the UVM Health Network. So I'm going to let Sarah take it away. You should be able to see her presentation. If you have questions throughout, there is a Q&A box at the bottom right of your screen. Please submit questions through there and we'll hold them until the end of her presentation. Sarah, you can go ahead.
Thank you. Thank you, Katie, and thank you everyone for having me today. So as Katie said, we implemented an e-visits program at one of our adult primary care sites, and I am going to take you through the process that we followed. What is an e-visit? I know that we are, in speaking with other teams, I know that we're one of the few in the area and in the region doing e-visits. So what is an e-visit? An e-visit is asynchronous. It's an online exchange of information between a patient and a provider. It's also considered store and forward. So it's similar to an e-consult, except that it's between a patient and a provider, not provider to provider. An e-visit is ideal for patients who are in good health. And really, an e-visit is also more ideal for a patient who is already established within a clinic, not necessarily on that provider's panel, but in that clinic, so they have access to their health information. An e-visit is not a live encounter, and it's really not meant to address any urgent issues. So at UVM Medical Center, we rolled out our e-visit program in July of last year, 2018. Some background on UVM Medical Center. Our hospital is located in Burlington, Vermont, and we are part of a health network which spans through northern New York and Vermont. So there are 3 hospitals in Vermont and 3 in New York, and we make up UVM Health Network. With the medical center in mind, we have 4 adult primary care sites and 5 family medicine sites. And we chose one PA who was really interested in this, and 1 adult primary care site. So Essex is the site, and that's in Essex, Vermont. It's kind of a small town, but a really busy clinic. She was really interested in doing this. So she was our pilot provider, and to date, she's done the majority of the e-visits because we're technically still in pilot stage. As of the end of September, she had done 161 e-visits. That's specific e-visits, not patients. There have been some patients who do them continuously for different things, but that's 161 visits. We rolled out 6 questionnaires. 5 of them were based on Epic's foundation build. So we took their build and really were able to put our own content and build on top of that. And then one of them, Sarah, who's our pilot provider, actually helped create one herself, and that was a tick bite one, so that was really exciting. We've been charging patients a $25 out-of-pocket fee for this. We're not billing insurance. We know that this is not being covered, so we're not even going through insurance. We are simply sending a bill out at the end of the encounter. And what we did also for Sarah's schedule is we put time at the end of each session for her to spend time on e-visit. So I think we did a half an hour before lunch and a half an hour at the end of the day when we got started with this. So why e-visits? We really wanted to help with communication between patients and their providers. We want to help patient satisfaction, and we want to decrease those non-necessary urgent care visits or emergency room visits We know that our primary care providers have over 5,000 encounters with non-urgent issues every year. So we did do some data research, and we looked at the indications that the Epic Foundation provides versus what we're seeing in clinic, and kind of crossed those to match which questionnaires it made sense to roll out first. And we found that we were able to address a lot of the things through the e-visits, which did decrease the non-urgent visits overall. So some use cases, this is, I think, pretty obvious when you're thinking about avoiding those unnecessary visits, also those unnecessary travel times and sitting in an office if you're sick or you're surrounded by people who are sick. So one of the questionnaires we have is influenza. And, you know, if patients aren't feeling well, they don't want to come in and sit in a waiting room for a while or be around people who aren't feeling well. So that's a nice benefit to this, is patients can anywhere in the state of Vermont complete this questionnaire if they're attributed to that site. Another one is a UTI. You know, you're not able to miss work, you can't find childcare, things like that. Kind of those usual barriers that we can help with telehealth overall, we found are good use cases here too. So this table shows the questionnaires that Epic Foundation has built already and supplied. So back pain, diarrhea, headache, red eye, urinary, cough, fatigue, heartburn, sinus problems, vaginal discharge, and then other, which is very vague, but you can build your own. We again had a builder from our Epic team, and she did an amazing job partnering with Sarah, who's our PA, to go through all of that content and then really vetting out what was clinically appropriate, the language that Sarah was comfortable with, and creating smart phrases and diagnoses, and then a letter back to the patient. So they really built on that. We knew that patients had to have a My Health Online account because this is where the encounter starts. So patients log into My Health Online, they select e-visit, and they go through the questionnaire. We also knew that patients needed to agree to terms and conditions. Most of that language is saying that they agree that they're in the state of Vermont, because Sarah's licensed in Vermont, so we need them to be here. Just consent for telehealth in general, saying that if it's an emergency that they should call 911, not go through the questionnaire, things like that. We also knew that we had an option in how we were collecting that fee from patients. You can build the workflow so that in Epic, patients are entering a credit card before actually being able to start that, but we didn't want to deter patients, so we decided to collect the fee on the back end. And then obviously our providers have to have access to Epic so that they can get this in their in-basket. So our project team, we had Sarah, who's our provider champion. We had James, who is our practice supervisor. We had a couple of RNs from our primary care site, so they could really speak to the current workflow, the triage process, you know, phone call volume. We had a director in the medical group, so she could make sure that the work we were doing was lining up with the overall goals and measures, patient satisfaction, things like that, that the medical group is tracking, kind of give us that high level viewpoint. We had marketing involved. They helped us with all of the patient-facing materials, signage, terms and conditions. They were a huge help with all of that. We had people from our Epic team, so we had someone come in and build, and then we had someone come in and help us train. We have professional revenue on here because what we did for the collection is we created a Z code. So in the level of service, Sarah's putting in a Z code that we had created internally, is submitted and tells our PRD team, ooh, we need to send a bill to the patient for $25. We also had a patient advisor pulled in. So we have a pretty robust patient advisor team here within the network, and they come from all different aspects in the community and around the state. And we pulled someone in to help us just make sure that from a patient perspective, it would be addressing what the patient would want to get out of it. That was really fun and helpful. And then the telehealth team, so that's me. I was basically just the project manager through the process, and I documented everything and, sent out too many agendas and notes and all of those types of things. So when we got started doing this, we knew Sarah wanted to do it. We knew what our goal was, but we weren't exactly sure. Do we charge patients? How much do we charge patients? What's a realistic turnaround time? How long are these really taking our providers? So we were lucky enough to touch base with 2 or 3 other organizations who had programs, and we talked to them about all of their lessons learned and their processes, and that was really helpful as we designed our workflow and patient-facing materials and things like that. We met bi-weekly for about 6 months. This was actually one of my first projects when I came on board in this role here. So we started meeting, I think, in February of 2018. We rolled out in July, but we did meet afterward just to keep on track and making sure that everything was functioning well. So we met bi-weekly. We addressed the build. We talked about questionnaires. We talked about who the appropriate patients would be for this, because we wanted established patients already, as I mentioned in the beginning, but we didn't want just any established patients. We really wanted patients whose information was more up to date. So we sent out letters to patients who were established in the clinic and had been seen within the last 12 months. So we thought that would be a good base of patients to start with. We had to work through the operational workflow, the billing, training, marketing, patient satisfaction. We wanted to make sure that we were also getting feedback too. We really wanted to understand the impact that we were making on patients and hoping to help, cross off some barriers for them. Once we determined the questionnaires, obviously we did the build. The 6 questionnaires that we chose were cough or influenza, cold or sinus, yeast infection, red eye, urinary symptoms, and then tick bite, which is the one that Sarah worked with Vicky to build. Out of the first 5 symptoms, those comprise about 3,000 visits in FY17. So we felt really good about that volume too. This slide shows our operational workflow, and the boxes are kind of small, so I apologize. I do this all the time to people, but basically this shows swim lanes and touch points of where the handoff is or where the patient's communicating along the way. So once the patient decides they want to do an e-visit, they log into MyChart. MyHealth, sorry, we just changed the name a couple weeks ago. They log in, they select e-visit, they do the terms and conditions, they select a pharmacy, they go through the questionnaire, they review the questions, and they hit submit. The way that we have it set up is that all of the e-visits are going into our triage nurse pool, and he or she is taking a look to make sure that really it's truly not an urgent thing. So if he or she reviews it and something's popping out that needs to be addressed quickly, the nurse would call the patient and say, do you need an appointment, or what's really going on? How can I help you? If not, then the e-visit gets forwarded to Sarah. It goes into her e-visit navigator in her in-basket. She clicks it, opens it, and is in there able to select the diagnosis. She can review all the questions, do diagnosis, do prescriptions through there, and compose her message back to the patient through there. And then again, in her level of service, she selects the Z9977, which we created internally. That triggers PRD to send the bill. She closes the encounter. A note goes back to the patient through MyHealth, and the loop is closed. If anything further needs to happen, the patient could always call the clinic back, but we've found that probably 99% of these really are triaged, diagnosed completely through the e-visit process. This is a slide that shows a tiny piece of the build. So Vicky, who did all of our Visio workflows for the build, created lots and lots of sheets that looked like this, and they spent a lot of time going through every question because, of course, there's an algorithm behind all of these questions and a decision tree, and as you can see, branches. So just wanted to show a snapshot of what part of the build looked like. She has some really great documents that she shared with us. This is what it looks like, again, from the patient's perspective. So over to the left, this little box, they would go to medical information, messages, e-visit, and that launches this questionnaire section. And then this is what some of the questions, this is a red eye questionnaire, and this is what some of the questions look like. And basically they click, 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 and then hit next all the way through. For Sarah or other providers, this is part of what it looks like on their Epic. They can see the question that was asked and the answer that the patient gives. This is not an expanded view. This is just an overall view from her in-basket. We also, again, wanted to collect patient satisfaction. So we created a survey monkey that our practice supervisor sent out via email to patients who had had e-visits from the previous week. And these are the 5 questions that we asked. Unfortunately, we had a very low collection rate of the patient satisfaction survey. But on the flip side of that, all of the surveys we did receive back were 4s and 5s. So these were all on a 5-point scale, I think 1 being low, 5 being high, which was really encouraging, but disappointing that we didn't get a lot of feedback back because we were really hoping we would. In terms of patient demographics, we also found that more females have been submitting and utilizing this than males. So it's about 80% to 20%. And again, this is as of the end of September. There's more data in there, obviously, and we're closer to about 170 questionnaires at this point, but the majority has been female. Average age is about 45 years old. The volume, this is broken down by symptom type. So colder sinus is way far in the lead. Urinary symptoms is second, and red eye, yeast infection, cough, and then tick bite. And I should mention that with e-visits too, you can't pay, patients can include media in there. And what I mean by that is if it is a tick bite, they can insert 1 or 2 pictures into My Health to show the provider the tick if they still have it on, or just the rash or the area where they think they were bit. And then for eye, they can also take a picture of their eye or eyes and include that too. So when I went through the in-person visits, just for these indications, for the established codes, the time-based, the 99213 through 215, versus the e-visits, it was kind of fun to compare the percent of indications seen in clinic versus e-visit. So the blue is e-visit encounters, and the green is in-clinic encounters. And you can see that for a few of these, we actually had more e-visits submitted than patients were coming in to be seen for. So interesting, and we'll definitely track this over time to see what more of an impact we'll have. And in the future, I think we will build out more questionnaires, but we want to expand them to other sites first. So what we also tracked, or what I also tracked, was miles saved. It's really interesting to me to see different benefits and different ways that we are helping our patients. So a lot of the patients who go to that clinic are actually from that town as well. So we did find that a lot of the patients are a pretty high, a third of the patients who did e-visits are from the same town. 54% came from within 10 miles of the clinic. The farthest was about 40 miles away. We saved over 1,300 miles, which is pretty substantial. So again, something else that we'll track over time. things that we learned, really understand the resources that you need as you build. Make sure that your clinical and support staff are feeling empowered and able to speak to this process, because they speak with patients all the time. So if a patient is calling and wanting an appointment for red eye, do they really need to come in and be seen, or is this appropriate? So that's something that you can work with leadership and your operational team to speak with patients about. Administration buy-in is absolutely necessary. Clinical leadership is imperative. Our collection rate is about 50%. So we found that charge, it was sent by a bill in the mail. About 50% of our patients actually paid it, which is, it sounds, maybe not so high, but in the beginning we were about 30%. So that's encouraging. We are not sending this to collection. So if a patient doesn't pay for it, they're just not paying for it. Again, we're not getting a lot of feedback on it. So Sarah actually said the longest amount of time she spent on one e-visit was 10 minutes. So it's not average, but the longest is 10. She usually spends about 5. And again, less than 1% has turned into an in-person visit. And I think there were either 1 or 2 patients, and one of them actually needed to see their pulmonologist. So he or she really shouldn't have initiated the process from the get-go. And in that circumstance, we do not bill the patient. If it turns into an in-person visit, we don't send that bill. Next steps, we have 8 more sites that we're rolling this out to within the medical center. Our affiliate hospitals went live with Epic actually last week. So we are working with them and our other sites to be able to roll this all out. We're hoping January, February. So we're gonna, pull back on marketing and patient satisfaction and, training teams and get everybody comfortable. And we're really hoping that all of our patients in our network can benefit from this service. And that is all I have. Thank you so much for listening.
Thank you, Sarah. So if you have any questions, please submit those through the Q&A. We did get a couple questions that came in.
Sure.
So has there been any discussion about capturing daily data from the diabetic population, such as daily blood sugar readings or weight, to better manage their symptoms?
So that's a great question, and something that I recently discovered. I've been perusing Epic's user web. You can set up, so the questionnaires that you can set up for patients differ from e-visits because they don't get routed necessarily to an in-basket, but you can set up questionnaires for patients to go in daily or monthly and fill in information. So we are starting to think about that for specific disease states or chronic conditions, things like that. That's a great question.
Excellent. And another question that came through that you did actually address, but it's worth mentioning again, and I'll ask a different question after it, is any billing codes used? Now, I know you mentioned that you internally created a Z code to generate a charge to the patient. But in addition to addressing the any billing codes used question, Sarah, could you maybe talk about, has UVM looked at billing Medicare specifically with the new G codes that were proposed at the beginning of this year?
We have not yet.
Okay.
I suspect that's something that we will look at next year, or at least start, looking around for information. That's a great question too.
Right. And then just to address this individual's question around any billing codes used, you are not billing insurances right now for this.
Correct. Yep.
Next question that came through was, what percentage of the PA's time would you say is spent on e-visits? Does she see other patients in the downtime?
Yeah, great question. What percent does she spend? Low. She probably gets 2 or 3 a week, and that's probably a half an hour total, maybe 45 minutes. They don't take her very long. So really she's maintaining a normal clinic schedule. She has a couple admin days just because she does anyway. And she's getting to them when she can. I think in the terms and conditions, we outlined that you should get a response within 48 hours, but she's been finding that generally within 8 hours within the business day she can respond.
Oh, wow.
Yeah.
Okay, that's great.
Yep.
And then another question that I just thought of was, this is specific to the Epic system. Are you aware of any other examples in other EHRs where this might be rolled out? Because I'm just thinking of other partner types on the line who don't have Epic. If they wanted to replicate this, where could they look?
I don't know.
Okay, nothing's coming to my mind either, but it's such a unique program specific to Epic that if it could be replicated, maybe that's something we can both look into.
Yeah, I'd be happy to do some research.
Okay. Another question that just popped in: how did you arrive at the figure of $25 for a patient payment?
That was something common that we heard from speaking with other sites, and our leadership felt that that was appropriate because it's similar to a copay.
Okay, yeah, that makes sense.
Yep.
I'm not seeing any other questions at this time, so we will wrap up this part of the call. So thank you so much, Sarah. I will be sharing Sarah's slide deck in the meeting notes later this week. And of course, if you ever need to reach Sarah, I will share her email, if that's okay with you, Sarah, in the meeting notes.
Absolutely. Yeah, yep, I'd be happy to talk more if anybody wants to.
All right. So next up, we are going to hear from DOH specifically, as well as OMH, OASIS, and OPWDD. I do believe they're all on the line. So Megan, I just made you a presenter. I can see your screen now. So Megan, Amy, Carmelita, and Dr. Virginia Scott Adams are going to give a brief recap of the presentation and discussion that was provided at the North Country Telehealth Conference about a week and a half ago. So for those of you who are on the line who attended that, this may be a good refresher for you, or a chance to maybe ask your question that you didn't have time to ask because we did unfortunately run out of time that day. So I'll let you take it away, Megan. You can go into the interagency telehealth guidance, and then we'll talk a little bit more about the other three agencies after that.
Great. Can everyone hear me?
Yes.
Okay, great. Hi, everyone. This is Megan Procorum. I'm the telehealth lead for the Department of Health's Office of Primary Care and Health Systems Management. So this is the regulatory and surveillance arm of the department for our DOH licensed facilities and programs. I'm going to just level set, provide a high-level background of our state telehealth legislation. So like the majority of other states, New York has what's known as telehealth parity. It was first enacted in 2014, then subsequently amended. The most recent expansion occurred in 2018-2019 enacted state budget, which added additional definitions to originating and distant site for Medicaid reimbursement. But the statute overall requires that services provided via telehealth be reimbursed if they are reimbursed if provided in person. So parity in terms of reimbursement for services for both commercial insurers and the Medicaid program. So we have, for the state, we have reimbursement parity. What we don't have within insurance law is payment parity. But we do have reimbursement parity. So if a service is covered, if the provider offers it in person, then it should be covered by a payer if it also is provided via telehealth. So this statute amends both sections of insurance law and public health law. So insurance law is what is applicable to our commercial plans, and then public health law, that's what applies to the state Medicaid program. This slide has the definitions, the statutory definitions of telehealth in both parts of legislation. So you can see that it's very similar and it's very broadly defined, where it just states that it's the use of electronic information and communication technologies by a healthcare provider when they are not located in the same site as their patient. Public health law goes into a little bit more detail on what services are included, such as assessment, diagnosis, consultation, treatment. So public health law goes on in section Article 29G to further define the 3 specific modalities that can be reimbursed for, as well as eligible originating site where the patient can be located and distant site practitioners. I'll get into that in a little bit, but I want to highlight for everyone that for insurance law, only telehealth is defined in legislation. And then it's really, that broad definition really allows for individual payers and plans to determine originating sites, distant site practitioners, and modalities. So just to note that, and for folks to be mindful that you'll really need to confirm with individual payers regarding their policies and their contracts. But nothing is outright excluded based on current statute, but one must follow up with individual payers. And of course, as Katie mentioned, the new benefit for the different types of electronic communication under Medicare, you need to be mindful too of the restrictions on Medicare. So as part of the most recent expansion to public health law, a new section was included that authorized the issuance of a single guidance document between DOH, Office of Mental Health, Office of Alcoholism and Substance Abuse Services, and the Office of People with Developmental Disabilities. So we've been working across these agencies to develop that. I overall want folks to be aware, Sarah from UVM touched on this a little bit when she mentioned her provider, is licensed in the state of Vermont, and the terms and conditions for the e-visits were patients needing to be located in Vermont. That's a really important point to recognize that if a patient is located in New York State, then that provider, that telehealth provider, also needs to have either a license or a certification to practice in New York State. So that's State Education Department law and regulations, so those all apply. And then you also need to be mindful of all the laws, rules, regulations, and standards and competencies for the underlying telehealth service. So I mentioned that, SED licensure, but also scope of practice rules apply. So New York State scope of practice for the various licensed professionals apply. And then HIPAA is a big, thing to need to consider. And then also separate, mandates for obtaining patient consent and maintaining medical records. So the next few slides are going to outline some of the major differences between the agencies regarding telehealth. And so this first slide shows the different telehealth modalities that the various state agencies recognize. So I want to also point back to, for folks to be mindful that, that broad definition of telehealth under insurance law does allow for reimbursement of all applications and modalities, but you need to be mindful of the specific contracting agreements for various modalities and services. Through the Department of Health, from the Medicaid program, per public health law, there are 3 defined modalities, and these include telemedicine, which is defined as the synchronous live video conference between a patient and provider at originating site and a distant site. And then store and forward technology. This is asynchronous. The state statute actually includes language that it's the transmission of patient health information from a provider at an originating site to a distant site telehealth practitioner. So our state law actually says that it's the provider is at the originating site, and it's being this, the record or the image is being sent to a distant site provider. And then remote patient monitoring as the third modality, which is also defined in state statute, and it includes both asynchronous and synchronous communication. For the other state agencies, OMH has telemental health, and OASIS has telepractice. And these regulatory definitions align with telemedicine. So telemedicine, telemental health, and telepractice all have a similar definition that involves the synchronous use of live video conferencing. And then for OPWDD, we've got their regulations state that they recognize the modalities that are defined in public health law for Medicaid reimbursement. So the same three modalities are recognized between Medicaid and OPWDD. So a few things to be mindful of. OMH and OASIS really just only utilize the live video conferencing. So for our next slide, the difference in regulations between the various state agencies. So for Department of Health licensed facilities, our Article 28, and even home care licensed agencies, we don't have regulations that are specific to telehealth. We really recognize that telehealth is considered a modality to deliver a service and not necessarily a regulated service in and of itself for our licensed facilities and organizations through the Department of Health. That being said, the Medicaid reimbursement that's defined in public health law, are applicable for the Medicaid population. So then for OMH, OASIS, and OPWDD, each of these three agencies have regulations that allow for services to be delivered via telehealth for OMH and OASIS through telemedicine, and for OPWDD through the three modalities outlined in public health law. And OPWDD will be providing additional clarification on what services that can be delivered via an ADM, an Administrative Directive Memorandum. So the regulations for OMH and OASIS require that OMH and OASIS licensed sites need to get agency approval to use telemental health and telepractice. And between these two agencies, this process is very similar. It's the submission of a plan and attestation. And this is different than DOH or OPWDD licensed agencies, where there is no specific approval that is needed. If you have only an Article 28 license overseen by Department of Health, you do not need approval to utilize telehealth. And then OPWD will be issuing that ADM to outline what services can be utilized to deliver via telehealth. And just to note that also their IPSID services and reimbursement are not allowed via telehealth. Our single guidance document will have sections on reimbursement. But just quickly, you really need to be mindful of the payer type of different patient populations, because, if they're Medicare, that's your geographic location is going to come into play. If it's Medicaid, that's public health law. And as I mentioned, there's 3 specific modalities that are eligible for reimbursement. Originating site is defined, distant site practitioner types are defined, and the most recent policy regarding Medicaid reimbursement is through a February 2019 special article on medical aid update, and the link is there. Happy to send it to anyone who might need it. And then for insurance law, I mentioned there's a broad definition of telehealth in statute. The Division of Financial Services, they reference telehealth in their model contracts, and those are available at that link for those that are interested. And then quickly, this is my last slide. This is the quick overview for the other state agencies. OPWDD regs in their ADM, allow for telehealth services that will be more specified in the ADM that be reimbursed by Medicaid if it meets the public health law requirements or through a health maintenance organization. And then for OMH and Oasis, their regs authorize approved providers that are defined in their regulations to submit Medicaid claim for telemental or telepractice through the originating site if the following requirements on this slide are met. So, OMH has recently expanded their regs so that the client can now be in the home or other temporary location similar to Medicaid reimbursement through public health law. So the claim would then be submitted through the site that the patient is enrolled in, and similarly through Oasis. And now that wraps it up for me, and it's a good segue to my colleagues at the other agencies.
Excellent. So I think we'll turn it over to OMH. So Amy, if you'd like to make a few comments related to what you spoke to at the conference. And while we're waiting for Amy to get on the line, we have a couple questions for you, Megan, actually, while we're sitting here waiting. Has there been any movement, to your knowledge, to add payment parity language in New York state law? And is there anything that can be done to advocate to add payment parity into New York state law?
Last legislative session, I believe there were some bills that were sponsored or introduced regarding this. We're going to be entering a new session, starting in January. So that would be done through, legislative action. Something that us at the state agencies are not involved in, but that is a separate process that folks working with their legislatures can pursue.
Excellent, thank you. And Amy, you are unmuted.
Okay, thanks, Katie. I was talking away and then I heard you cut in. So just very quickly, we did expand our regs on July 3rd of this year, Part 596 regulation. We changed the title from telepsychiatry to telemental health. We expanded our practitioner types to now include psychologists, social workers, mental health counselors, marriage and family therapists, creative arts therapists, and psychoanalysts. We've expanded where the practitioner can sit. So for prescribers, they can be located anywhere within the U.S., and the other new practitioner types can be located anywhere within New York State. We did align with Public Health Law 29G, as Megan mentioned, and we expanded where the client can be located, so they can now be sitting in their home or other temporary location within or outside of New York State. We've included our ACT programs and our PROS programs as eligible treatment sites. And we didn't make any changes to the application process. As Megan mentioned earlier, there still is an attestation. We need to look at the policies and procedures for the originating site, and then we approve through our regional field office. And I think that's it at this point for our updates.
Okay, thank you. Next up is Oasis. Carmelita, I do see you are on the line, so hopefully you're unmuted. If not, send me a quick Q&A and I can unmute you. Not letting me unmute. Could make her panelist. Okay, you should be unmuted now, Carmelita. Let's see. While she's figuring out getting audio, we also have OPWDD on the line. Dr. Scott Adams is on the line. If you're able to speak, you can certainly feel free to give some updates related to the ADM. There have been some questions that have come in about that. So I don't know. All right, Dr. Adams, you're unmuted.
Great. Can you hear me?
Yes.
Okay, fabulous. So OPWDD continues to move forward to expanding the use of telehealth within the OPWDD state-operated and voluntary sectors. We do continue to hear stories about individuals and agencies who find that telehealth is extremely beneficial to them. OPWDD will be issuing an ADM that will establish requirements pertaining to telehealth. And as I mentioned at the conference, the ADM will apply to providers as well as to agencies and programs supporting individuals. So the ADM is going to apply to providers who are working under an Article 16 clinic. And those providers will be able to deliver services via telehealth in accordance with the requirements established by the ADM. In addition, the ADM will establish requirements for agencies and programs that are supporting an individual. For example, an individual living at a certified IRA may have VSP staff who are assisting the individual with the encounter, and so the ADM would apply in those settings as well. The ADM does not apply to providers who fall under another umbrella. For example, a provider may work in private practice. In such case, the ADM will not regulate that provider who works in private practice because it will not apply to them, but the ADM requirements would establish requirements for the provider agency or the agency supporting the individual with the encounter. So I just want to make sure that that point's clear because we do get a lot of questions surrounding that. So again, if an individual is seen by a physician who works in private practice, that physician can deliver a service via telehealth, but they are not going to be required to abide by our ADM. They would be required to abide by any requirements set forth by the payer, right? So if it's a insurance plan, DOH, et cetera, Medicaid rather, not DOH, Medicaid or another insurance plan. The ADM is going to cover various topics. Just to give you an overview of what those topics are, it will establish requirements pertaining to informed choice, and OPWDD specifically uses the word choice versus consent because consent has a defined meaning within our system, and some of our individuals may be able to agree to or understand receiving services via telehealth, and so we want to make sure that informed choice is used rather than requiring a full consent capacity assessment. In addition, the ADM will pertain to privacy settings and environment, including ensuring that there is a space where an individual can receive the service that is private and that they're comfortable in. The ADM will establish requirements surrounding the use of a telepresenter or support staff who assist the individual with the encounter. The ADM will also cover topics such as responding to transmission failures and procedures for responding if the session is cut off early. There's requirements pertaining staff training, infection control, billing, service documentation, and technical requirements. One other point before we answer any questions that you have is that the ADM will establish CPT codes that may be used for telehealth, and those CPT codes are pulled from the most recent CPT manual that was published by the American Medical Association. Association. If you look in the CPT manual, you will see that those services that can be delivered via telehealth are clearly defined, and they're actually included in an appendix in the manual. So you'll want to go back and look at that because our ADM will mirror those CPT codes.
How are you?
All right, thank you so much. There was one question that came in for you. So Megan had mentioned that, of course, there's no additional approval process for Article 28 clinics, but what will this look like for Article 16 clinics? Will there be an approval process for telemedicine?
That's a really good question. There is not specific approval that will be required to deliver services via telehealth. However, when clinics are certified, they're authorized to deliver a certain menu of services. If they are authorized to deliver that service face-to-face, then they are thereby authorized to deliver that service via telehealth when done so in accordance with the ADM. So they're not going to have to complete a separate application, but they're still going to only be able to deliver those services that they're authorized to deliver or provide.
Okay. And when will the ADM be published?
That is a great question. I am hoping that it will be published over the coming months. I'm not sure where it is in the approval process, but I can certainly keep folks up to date as that time nears.
Okay. Thank you so much. All right, Carmelita, you are unmuted and you can wrap up the agency update with OASIS.
All right, great. Can you hear me?
Yes.
Perfect. So my comments will be pretty short. As mentioned previously, OASIS certified providers need to seek office approval. We have a designation process in accordance with our Part 830 regulation. It's basically just submitting an attestation and a plan to both the regional office and our certification unit, and then providers get a designation added to their operating certificate. Our regulation is actually open for public comment right now. We have two changes that we're making to the regulation. We are adding counseling as an approved service, which can be delivered via telepractice. We had previously not included that, but we've had providers operating and delivering services via telepractice for about 1.5 years now. Some of them were allowed to do so with a waiver to provide counseling services. So the agency's kind of changed their position, and we're now allowing both group and individual counseling to be delivered via telepractice. And then we're also amending the regulation to add that a patient can be located in their home to receive services. We have a telepractice standards document which accompanies our regulation. It's got a lot more detail in it and what we expect from providers in delivering these services. So that's also posted on our website. It was last updated in August of 2018, and it will actually be updated when our new regulation becomes effective. Our public comment period ends at the end of November, so we're anticipating probably sometime in December or January. And those documents will be posted on our website, and then they'll also go out to all providers. So those are some changes coming in the near future. And then kind of the two larger questions that the agency always gets are whether or not buprenorphine induction can be done via telepractice, and whether or not peer support services can be delivered via telepractice. So in terms of buprenorphine, there is one exception. The rules around buprenorphine induction are actually federal rules. They're not state rules. So there is one exception where buprenorphine induction can be performed via telepractice, and that is if the patient is physically located with a DEA-registered provider, then induction can be done via telepractice. And then in terms of peer support services, certified recovery peer advocates are actually not included in the public health law as a professional that can deliver services via telehealth. In addition, I think it's the the view of the agency, that peer support services are really intended to be a one-on-one, face-to-face, in-person kind of service, and we haven't really entertained the idea of adding SERPAs to the public health law, or you know, seeking to deliver those services via telepractice. So I don't anticipate that that will change anytime soon. I know that's usually a bigger question that folks have. And I think that that is pretty much it for our updates, unless there are additional questions.
Nope, the only question that came in was around SERPAs, which you just addressed. So no other questions have come in for any of you. So thank you to the four of you again for the recap. Much appreciated, so that more folks could kind of hear that message. So with the last couple of minutes that we have, I wanted to provide a few quick updates from the partnership. I'll first check and see if my colleague Bob has any updates that he'd like to provide quick.
Just a quick update on the diabetic retinopathy program. We're up to 315 visits year to date, and we've had 30 instances of finding, and we are having pretty good luck with reimbursement. And of course, I will go into more detail on that at the beginning of the year when I present where we are in the program. That's all I've got for right now.
All right, thank you. So a few other upcoming events. We are doing an educational webinar on Tuesday, December 17th from 1 to 2 p.m. This will be presented by Mary Lowry of Dartmouth Hitchcock Connected Care, and it's going to be on operationalizing the expansion of telemedicine services in a complex reimbursement and regulatory environment. So I foresee this being a very valuable webinar to talk about reimbursement. So I certainly encourage all of you to register. I will be sending the link in the meeting notes. And then a few other quick updates, a quick North Country Telehealth Conference recap. We had close to 200 attendees, which was really exciting. It was our most attended conference yet. I know some of you on the line were there, so I thank you for coming and supporting the partnership and this annual event. If you haven't yet taken the post-conference survey, please do so. It was sent out, and a reminder was sent out early last week. And then last but not least, the North Country Telehealth Partnership just hit a great milestone of tracking over 10,000 telehealth encounters since the program began in late 2014. So thank you to all of you for your continued support and your efforts in expanding telemedicine, because we could not do this without you. Stay tuned for updates on 2020 Learning Collaborative dates. We are working those out currently, but we can expect that the next Telehealth Learning Collaborative will be likely at the end of January. We always do these on the third Monday of the month, every other month, but that happens to be President's Day in January, so we'll likely do it the week after. So again, thank you for supporting us throughout 2019. This is the last Telehealth Learning Collaborative for the year, and we hope you can join us on Tuesday, December 17th for our educational webinar. Stay tuned for meeting notes and slide decks to go out later this week, and have a great rest of your week.